Baker's cyst is a protrusion, or more specifically, what they would call an effusion, that herniates between the two heads of gastrocnemius. So that medial and lateral head, the space in between, effuses or bulges out. Often this is due to meniscal issues. Just to recap, if it hasn't been mentioned before, between your femur and tibia is a pad sitting on top of the tibial condyles called the meniscus. It is a C or U-shaped pad of cartilage that buffers the articulation between the knee to help reduce friction, and the meniscus can often get injured. In this case, usually post-meniscal injury, the likelihood of a Baker's cyst will increase. But even without meniscal tears, the sac in that space in between will bulge out. Sometimes things like osteoarthritis are also associated, a weakening of the joint space. There will be a visible swelling and definitely pain in the posterior knee, what we call the popliteal fossa. So the first thing with Baker's cyst is to have a deeper inspection on if there is meniscal tears, meniscal compromise, or arthritis. So for people that this is new to them and you notice a Baker's cyst and it could have just happened during a workout or during some version of the exertion, they need to get some sort of diagnostic answers as to what occurred in the knee that formed this Baker's cyst. You will see a swollen, often tender mass, and it will be palpable in the posterior knee. Any treatment for this has to be both conservative and targeted around the abnormality that created it. So this is not something that would be indicative of hands-on intervention. The biggest reason really for mentioning is to advise you to stay away from a Baker's cyst and to advise your clients to get deeper answers on why this cyst formed in the first place. There's something called a Doppler ultrasound that you can use to check for DVT, which is deep vein thrombosis. And a lot of times these cysts will be seen during these examinations. But again, they can also be seen visually. So if you run into these and they are confirmed, some of their posterior knee pain will be a result of this cyst, and they will have to consult with their primary for strategies around removing or dealing with this cyst, certainly out of our scope of practice, but you will see this at some point throughout your career.